Hello, my name's Dr. Stephen Lewis. If you're watching this, it's probably because you want to learn about the speciality of intensive care medicine, or because you're going to be placed with the Frimley Park Hospital Intensive Care Unit, or maybe even both. In this video, I will introduce the speciality of intensive care medicine by first covering a little of its history, how it is structured and organised, how we approach the critically ill patient, and hopefully in the process demystify some of the jargon that we use. I will then describe the Frimley Park Hospital Intensive Care Unit and cover a few specifics that may be of use to new starters. The intensive care speciality can be traced back to the 1952 polio epidemic in Copenhagen. Although polio could be a survivable infection, at the time the mortality rate was 80% due to people essentially drowning in their own secretions. Dr. Bjorn Ibsen, considered by many to be the father of modern intensive care medicine, suggested inserting tracheostomies, using positive pressure ventilation, cohorting patients in a dedicated ward with a nurse for each patient. By using this approach, the mortality rate was cut to 40%. Serendipitously, the blood gas analyzer, now a mainstay for monitoring in all critically ill patients, was also developed in Copenhagen using pH monitoring technology from the Carlsberg brewery. From these beginnings, intensive care developed into the speciality that it is today. As well as intensive care doctors, we also have specially trained nurses, pharmacists, physiotherapists, dietitians, technicians, microbiologists, all coming together to provide care for the sickest patients in the hospital. A recent development of intensive care has been the outreach team, which aims to project the skills and capability of intensive care beyond the walls of the unit. In Britain, about 50 years ago, a group of enthusiastic anaesthetists came together to form the Intensive Care Society. This is the oldest society of its type in the world. In 2010, the Faculty of Intensive Care Medicine was formed. It exists as part of the Royal College of Anaesthetists, but also has representation from many other colleges, physicians, surgeons, paediatricians included. Since 2012, it has been possible for doctors to undertake standalone training in intensive care medicine. However, dual training, together with another speciality that complements intensive care, usually anaesthesia, renal, respiratory, acute or emergency medicine, remains the most popular. Throughout its evolution, an enduring feature of intensive care medicine, certainly in the UK, has been that it is a scarce resource. Intensive care costs in the region of £2,000 per patient per night, and the UK continues to lag behind countries of similar wealth in terms of number of beds per head of population. However, the central role that intensive care has played in recent pandemics, not least that of COVID-19, has raised its profile nationally. This, together with a drive to achieve better outcomes following major trauma or surgery, has increased the political will to expand critical care capacity throughout the UK. Now for a bit of terminology that isn't heard very much outside the ITU. When discussing how dependent a patient is on the care they're receiving, we often use a shorthand known as levels of ICU care. Patients who are just on normal ward level care are level 0. Those under closer observation, those are patients who are monitored, are under level 1 care. Those receiving single organ support, this could be a vasopressor, they could be on non-invasive ventilation, they might be on renal replacement therapy, they are level 2 patients. And finally, the most dependent patients on the intensive care unit are level 3 patients. These are patients who are either receiving more than one organ system support or who are sedated and on the ventilator, i.e. either intubated or with a tracheostomy in situ. When you first encounter a level 3 intensive care patient, it can be quite disconcerting. They are generally unconscious or possibly delirious, surrounded by many machines, any one of which can alarm at any given moment, and guarded by an intensive care nurse. Every day, many thousands of data points are recorded on them. Fluid balance, respiratory parameters, blood chemistry, to name but a few. It all looks very complicated, but you must remember that most intensivists are in fact quite simple folk. In fact, we've just taken the ABCDE process that you learn in ALS training and turned it into a speciality. Other videos in this series will deal with things like invasive ventilation, renal replacement therapy, and vasoactive agents. But putting these intricacies aside, if you take an ABCDE approach when assessing an intensive care patient, keeping in mind what they're doing for themselves and what's artificially being done for them, then you won't go too far wrong. The field of research is very interesting and active in intensive care medicine. Unfortunately, it tends to be the case that research demonstrates an absence of benefit for any given intervention. Therefore, intensivists have tried to group together all the things that we do think are of benefit into care bundles. For example, all sedated intensive care patients are nursed at 30 to 45 degrees to try and reduce microaspiration and therefore ventilator-associated pneumonia. The ARDS-NET protocol describes how to safely ventilate a patient using lower tidal volumes and lower pressures to try and reduce volutrauma and barotrauma. This will be discussed in another video. As for all hospital patients, we proactively use mechanical and chemical thromboprophylaxis unless contraindicated. Nutrition is considered very important, and we feed all patients where possible. Any patient whose gut is not fully absorbing feed will be considered for a proton pump inhibitor to reduce the risk of stress ulcers. Intensive care nurses turn patients regularly to reduce the risk of pressure sores. They perform mouth care, reducing the bacterial load in the mouth to try to avoid the risk of chest infection from aspirated secretions. Intubated patients are regularly suctioned and receive chest physio to reduce their sputum load. In the longer-term intensive care patient, physiotherapists also work to retain range of movement and rehabilitate patients by improving strength and balance. Even when the patient is physically improving, the work of intensive care is not over. Critical illness and its management can generate a great deal of psychological trauma, both for the patient and their nearest and dearest. The nurses keep a patient diary to help survivors in intensive care fill in the gaps in their memory. Intensive care follow-up clinics are also very important, helping survivors and their families deal with what has happened to them and address any ongoing concerns or issues. In order to benchmark themselves, UK intensive care units submit data to the Intensive Care National Audit and Research Centre Case Mix Programme, or ICNARC as it's known. This allows parameters such as the mortality rate of an intensive care unit to be compared with others of a similar type. Incidentally, if you're going to work in intensive care, it's worth preparing yourself for the fact that somewhere in the region of 20% of patients admitted to the ITU will not survive their hospital admission. I'd like to turn now to some specific details of the Frimley Park Hospital Intensive Care Unit. We are a 12-bedded facility which includes 3 side rooms. Each bed can be configured up to level 3, i.e. full organ support. We look after adults only, although in an emergency we do sometimes get involved in caring for children until they can be retrieved by the paediatric intensive care service. The day begins at 7:30 with handover from the night team. At 9 o'clock we hold a safety brief, communicating key important points between nursing and medical colleagues, things like bleep numbers, which patient has a difficult airway, which patients are on a sedation hold, things like that. Between the handover in the morning and about 10:30 or 11 o'clock, the intensive care doctors will review each ITU patient, and then there'll be a consultant-led ward round to make a plan for each patient for the day. This ward round will hopefully finish in time to allow an opportunity for lunch before a microbiology ward round with a consultant or registrar microbiologist at around about 2 o'clock in the afternoon. The afternoon is generally spent doing the jobs of the intensive care unit, changing lines, taking patients to CT for scanning, talking to relatives, although of course at any time of the day or night we may receive admissions. 7:30 in the evening, the duty doctor for the night will come on, and there will be another consultant ward round. All intensive care patients should receive 2 documented intensive care consultant reviews every day. There is consultant present until 10 o'clock at night, although of course we will always come back in if required. It is worth considering some of the paperwork that intensive care doctors at Frimley Park Hospital are required to complete. This is the Frimley Park intensive care admission sheet. Every patient, whether admitted from the emergency department, the wards, or the operating theatre, should have one of these completed, and it is frequently referred back to, particularly for patients who stay for a long time. This is the daily review sheet. The first page is completed by the intensive care junior doctor, who will make an assessment of the patient and create a treatment plan. This will then be reviewed on the consultant ward round in the morning, who will then revise the treatment plan as required. In the evening, there'll be a generally much shorter review for the patient. Normally, we will only write a couple of lines if anything has changed. You will notice that we allow much more space for lists of problems than we do for lists of diagnoses. Intensive care medicine generally takes quite a pragmatic approach, and it is often true that the problems that have brought a patient to the intensive care unit are not the same as the problems that keep them there. For example, the patient who was admitted following emergency PCI for ischemic heart disease may end up staying on the intensive care unit because they've developed acute respiratory distress syndrome and now require wean on a ventilator. Because intensive care uses powerful drugs that are generally not found or used anywhere else in the hospital, we have our own bespoke drug chart. This is helpful because it has sections pre-printed for signing for things like electrolyte replacement, insulin therapy, vasopressors, and sedatives. However, it does mean that when a patient is admitted from the ward and when they go back to the ward, they need their drugs transcribing back onto the buff drug chart used by the rest of the hospital. In time, when a new computer system is developed for us, it's likely that this will be replaced by a computer-based system. In summary, I hope I've been able to show you that although intensive care is a relatively young speciality, it's growing in national recognition and standing. Intensive care is a true generalist speciality, and we interact and take patients from every acute medical and surgical speciality in the hospital, including obstetrics. We take a pragmatic, systems-based approach to our patients. Whilst things can look complicated, the principles we used are in fact quite simple. I'd like to recommend that you view the other videos in this series for more detailed explanation of different aspects of intensive care. If you're watching this because you're coming to join us soon, and I do hope that you find your attachment interesting and enjoyable and useful. Please don't be afraid to ask any of my consultant colleagues or I any questions you have about any aspect of intensive care, and we'll do our best to answer. Thank you.